Long time since I heard that. Oh, did you? You were a Celtic...
I was, yeah.
Oh, cool, yeah. Joe just said, go Celtics. I said, it's a long time since I've heard that. Yeah. All right, Sony Media, that's not Celtic, you know.
See ya.
Okay, we all set, folks? Okay. Excellent. Well, thank you, everybody, for joining us. This is our 10th Healthcare Action Update. And before I jump into the topic today, I would like to provide an update about physicians licensed to practice in Newfoundland and Labrador, as well as nurses licensed to practice in Newfoundland and Labrador. In 2023, more physicians were licensed to practice in this province than in 2022. This trend has continued. In dialogue with the College of Physicians and Surgeons, we understand that in 2024, more physicians are renewing their licenses compared to this period in 2023. In Newfoundland and Labrador, 46 more physicians, or 11 family physicians and 35 specialists, were licensed in 2023 for a total of 1,607. When combined with physicians registered via the Atlantic Registry, which allows for greater mobility and flexibility for fully licensed physicians to practice anywhere in Atlantic Canada, this number increased to 201 more registered physicians. This means that more physicians are available to provide in-person or virtual care in Newfoundland and Labrador. So what this means is that there are more physicians licensed to practice. There are more physicians in Atlantic Canada who can practice in the province. And both of these help increase access for Newfoundlanders and Labradorians to care. These are steps in the right direction. These steps show that our recruitment plan is working. Recently, I've been telling you that we've recruited more than 70 physicians to work in Newfoundland and Labrador since April. It's exciting to be able to share with you today that we've recruited more than 80 physicians to work in the province since the beginning of the fiscal year. Months ago, we had recruited more than 400 nurses in that same time frame. That's now more than 450 registered nurses. With new graduating classes this spring and job offers made to upcoming graduates, we anticipate that number rising even further. Our incentives in this province are amongst the best in the country. It shows that we are competitive in a global competition. For example, a family physician can receive up to $450,000 in initiatives to practice in our province. Extra physician recruitment resources have been added at NL Health Services. Physician recruiters are located in the medical schools 3 days a week for direct engagement with medical learners and residents. Amendments were made to the Medical Act to add new categories of registration, associate registration, and clinical assistant registration. The medical regulations also create fast-track pathways for internationally trained practitioners who are trained and licensed in select countries. We've also been working with the College of Registered Nurses and practical nurses to make it easier for licensure and to find ways to make it easier for internationally educated nurses, including bridging for IENs who had been living in the province. Our come home incentives have been resulted in the recruitment of a number of different health disciplines. It is the most successful recruitment initiative that we've seen in the province. So we'd like to thank all health professionals who are seeking licensure to practice in Newfoundland and Labrador. And if you're from outside the province and would like additional information on working in our province, please visit workinhealthnl.ca. So turning towards our main update today, I'd like to say that this is a very special healthcare action plan, or action update. I find that our updates are always exciting, but there is something particularly exciting and heartwarming about our update today, pardon the pun, and what it means for healthcare, specifically heart and stroke patients going forward. February is Heart Month, and today we have some interesting news to provide about how care for heart patients has improved and how people will get the care they need in the future. One of the challenges we face when we provide these updates is being able to take the medical terminology and explain it in a way where you don't need a medical degree to understand it. So we will attempt our best. This first of 3 updates today is the expansion of endovascular thrombectomy, also known as EVT. First introduced in the province in 2022, EVT is a highly specialized surgical procedure where stroke-causing blood clots are removed from patients who are clinically eligible. An early evaluation of EVT has shown that it has led to an approximate 50% reduction in the patient's length of stay in hospitals compared to patients who had not received it. This means patients who receive EVT have better outcomes and their hospital beds become available for somebody else sooner. Because of all of this, NL Health Services expanded its use, and we anticipate reaching more people this year. Second part of our update is that access to clot-busting drugs for ischemic stroke treatment, also known as thrombolytics, has increased. These drugs should be given within 4.5 hours after stroke symptoms start, and their use has increased from 10% in 2018 to approximately 20% in 2023, which is the national standard. More people are receiving these drugs, and this means that they are having better outcomes. This is very exciting because more people are going home to live with their loved ones and in their communities. The third part of our update is the increased use of virtual heart failure management. It's crucial that patients get the care they need as soon as possible, and patients in virtual heart failure management can become stable on their medications in only 9 weeks through virtual appointments, compared to the 6 to 12 months that it can take through in-person appointments. These virtual heart failure management visits increased from 9.9% of the total in 2022 to 26.5% of the total visits in 2023. Building on the outcomes we've seen through these treatments, we plan to reach more people this year and beyond by expanding access to EVT across the province, starting in the Central Zone in the first half of this year. Continuing to promote public education about the need to recognize the signs of stroke, which includes FAST or Face, Arm, Speech and Time, offered through the Heart and Stroke Foundation. Implementing satellite cardiology clinics where a cardiologist will visit patients who do not have a cardiologist in their area, and ongoing planning for the new Cardiovascular Stroke Institute facility. This, of course, is in addition to the other actions that we've put in place, including our cardiac cath flights, also known as Heart Force One, which fly people from other regions of the province to St. John's to get their procedure they need sooner than expected. Heart Force One has continued its success with 16 flights so far, carrying 118 patients from Western and Lab Grenfell zones in the province, and I understand from Dr. Connors we've just started in Central. So this resulted in 428 days worth of beds being freed up at the Health Sciences Centre for other patients, plus more beds available at other hospitals across the province. In the last number of months, we've announced a partnership with the March of Dimes After Stroke program, which improves the transition from hospital to home for stroke survivors by providing them and their families and caregivers a personalized recovery plan, emotional support, and education. Access to resources and services in their community and hospital visitation with trained peer supports that have lived experience. So we're excited about this news today. You'll remember that there were some questions about the use of virtual care when we announced it in November. I think Dr. Parfrey took a little bit of a ribbing at the time.
I did.
So, let's be clear that virtual care is not replacing on-the-ground physicians and staff. Virtual care does, in fact, complement and improve our system, and it's used so that people can access primary and specialty care in communities faster when it is appropriate to do so. I mention this because, as I've outlined already, and we are clearly seeing the benefits of virtual care. Patients of virtual heart failure management, which has been used for months now, are becoming stable on their medications within 9 weeks virtually rather than 6 to 12 months in person. These are patients living all over the province who, because of their virtual heart failure clinic, are spared the need for difficult and unnecessary travel. This is a significant improvement. Additionally, a few weeks ago, you'll remember that there was a story in the media about a patient in New West Valley who is alive today because of virtual care. A patient arrived at the Kittiwake Health Centre, was in cardiac distress, saw a doctor virtually, then received the life-saving injection. And thanks to the virtual emergency doctor and the on-site health professionals, the story noted that the injection broke up the blood clots and kept the patient alive so that that patient could be transferred to a larger hospital about an hour and a half away and then airlifted to St. John's for the treatment that they needed. Emergency room diversions are going down and they will continue to go down. So to summarize, treatment is now being used in the province. It is leading to better outcomes for heart and stroke patients. They are getting the crucial care that they need sooner, and we are expanding on the use of these treatments to reach even more patients. I'll now turn the mic over to Cassie Chisholm, Vice President of Transformation within the Newfoundland and Labrador Health Services.
Thank you, Minister. I'm very happy to be here today to share the successes that our cardiac and stroke teams have recently had in increasing access to life-saving treatments and medicines. As ministers just described, our highly specialized surgical teams have brought endovascular thrombectomy, or EVT, to Newfoundland and Labrador, and that happened in 2022. This life-saving procedure for people who are suffering ischemic stroke must be performed within 24 hours of the onset of stroke symptoms. Early assessments have shown us that there's been an almost 50% decrease in hospital length of stay for those people who have received EVT in comparison to those who did not. In 2023, we expanded our program criteria so that more stroke patients could receive EVT treatment. And now in 2024, we're very excited to see EVT expand even further, beginning with Central Zone. Our teams have also seen a significant increase in the number of ischemic stroke patients who are receiving clot-busting thrombolytic drugs. In 2023, almost 20% of eligible patients were administered thrombolytics, which is the national standard in Canada. Doctors try to give these drugs within 4.5 hours after the onset of stroke symptoms. Ongoing public education here in Newfoundland and Labrador has really helped people to identify stroke symptoms and to seek out stroke care urgently so that they can be diagnosed and receive drugs and therapies like EVT in time. A quick way to remember the signs and symptoms of stroke is FAST, or FAST. Face, F for face, is it drooping? A for arms, can you raise both? S is for speech, is your speech slurred or jumbled? And T is for time, time to call 911. If you suspect someone is having a stroke, please call an ambulance, because emergency medical services will ensure that you are brought to the closest facility with the appropriate equipment to diagnose and treat stroke. And they will notify the hospital that you are coming ahead of time. Our cardiac team has also seen success with both the same-day fly-in, fly-out cardiac catheterization procedures, affectionately known as Heart Force 1, and the virtual heart failure management clinics Minister just spoke of. I'm sure Dr. Connors will speak to this more in a moment, but for now, let me say we are very happy to successfully find new ways to bring patients to the care that they need and to bring care to the patients wherever they are. These initiatives to transform heart and stroke care in Newfoundland and Labrador are based directly on recommendations from Health Accord NL to improve the mortality rate for cardiac and stroke in Newfoundland and Labrador, and to create a cardiac center of excellence in this province. Last year, we were so proud to announce the creation of the Cardiovascular and Stroke Institute. The planning for our institute is ongoing, and we are firmly in phase 1 right now. The first phase includes innovative initiatives like Heart Force 1, like expansion of our virtual care, and the cardiac satellite clinics that Minister Osborne just announced. These efforts are expanding access to cardiac care to patients across our province and will remain important parts of the new modernized cardiovascular and stroke program in Newfoundland and Labrador. The second phase is focused on organizational structure and will bring cardiac, stroke, and vascular teams under the umbrella of the Provincial Cardiovascular and Stroke Program. This is innovative in Canada, and we are extremely excited to be engaged. This will allow teams to efficiently collaborate so that the best care plans are created and tailored for each patient wherever they are in Newfoundland and Labrador. The final phase will see construction of our new facility. And I'll pass it over now to Dr. Connors, who is Clinical Chief for Cardiac Care with NL Health Services, and he'll speak a bit more.
Thank you, Cassie. Minister, I'm truly delighted to be here. The Minister talked about this being the 10th Healthcare Action Update, and it really is heartwarming, pun intended. Like, what the things that they just spoke to you about are true. I'm on the ward every single day. I see the people coming out of the operating room. I answer the telephone when people are at home waiting. The positive impacts that these changes have made are real and they're felt. We're in this place here in this province, and we lead the country in terms of heart and stroke disease. And I truly think that we need to innovate in the way that we care and the way that we all treat this burden of disease that is upon us. After all, it's 1 in every 3 of us that's going to be affected. So as a cardiologist, I feel the hardship of people on the wait list longer than we'd like them to be there. I see how hard our heart teams struggle to connect patients with the care that they deserve and they should have. We do deliver care. We deliver world-class care. And as I drove here today, one of the things that I thought about, what is the most important message that I'd like to get across? And that is that patients should be very confident that when they come, they will get the best possible care. I believe that right to the very bottom of my heart. I'm very optimistic, and the Minister and Cassie have summarized a lot of those things. We've got Heart Force 1 flying. Yesterday, it flew for the 16th time and took patients in from Central for the very first time. Our heart failure clinic has shown how strong virtual connectivity with patients can be. It's actually delivering care that is over and above what those patients could get in person. They're getting treatment faster and achieving goals of care in a more timely fashion without transport. You know, Cassie explained EVT and how we're bringing really new and emerging therapies to the population here in Newfoundland and Labrador and bringing our rates of treatment up to national rates. And one of the things that really excites me a lot, because it unites everything together, our heart teams, is that we have recruited a full complement. In fact, beyond a full complement, we have 5 cardiac surgeons operating on our teams now, which is more than in the history of Newfoundland and Labrador that we've ever had. These are world-class surgeons. They're here and they're happy to be here. Why are they happy to be here? Because of the investment of NLHS and the government, we've got wonderful things happening, like you've just heard, along with a new Cardiovascular and Stroke Institute being planned. So I see big changes, right? I've been practicing as a cardiologist for 25 years. These are real, these are important changes. And the future looks even brighter. Apart from our new Cardiovascular and Stroke Institute, you know, we continue down the pathway of innovation. We're looking at prehab and rehab. If you're waiting for heart surgery, well, why not have a program where we talk to you, we make you healthier, we tell you that your surgeon wants you in the best possible health when you come in. Let's talk to them then. And when they have their heart surgery, let's work with them to get back to work and back to their lives as quickly as possible. Satellite clinics, you know, we've always thought, let's bring the doctor to the patient as opposed to the patient coming to the doctor. On Sunday, I'm flying to Goose Bay. I mean, I want to be first out. I want to see what it looks like up there. I want to deliver clinics to people that don't have to fly down. You know, this will be something that is part of our standard work as we deliver cardiovascular and stroke care in the future in this province. So with that, I would like to conclude by saying these things are really important, right? I've been at this a long time, and this is transformative. I've never felt this kind of input, focus, and progress in the care of, I think, the most important disease process that we have affecting our patients here in Newfoundland and Labrador. I'll hand it back to the Minister.
Thank you. As you know, my job here is to try and influence the implementation of the calls to action that were recommended by the Health Accord. And I just would like to repeat a phrase that was mentioned in the tech briefing. For stroke, time is brain. So when a stroke is either caused by a hemorrhage or is caused by a blockage of the blood flow to the brain, that's an ischemic stroke. So if somebody gets an ischemic stroke, the sooner that clot is gotten rid of, the more likely they are not to have residual dysfunction, be gorked, as we say sometimes, and or die. So that whole process, pathway to care process, was the one that influenced the Health Accord the most. It thought about the pathway to care, the people recognizing their symptoms, an ambulance system that got them to a hospital with a CT scanner as fast as possible to determine whether they had an ischemic stroke or not, and then the application of thrombolytics or clot-busting drugs to get rid of their clot. That's a time-dependent process, and every minute saves time. So, and the thrombolytic drugs have to be given within 4.5 hours. So the fact that we have, during the time of the evaluation of the Health Accord and the recommendations provided to it, for me, it's a rejoice that we're now up to the national average, and that we are, instead of being at 10% of ischemic strokes getting clot-busting drugs, we're at 20%. You might say, well, what about the other 80%? Right? Why aren't they getting clot-busting drugs? And it's because they're not getting their CT scan within the 4.5 hours so they can get thrombolytics. So consequently, the endovascular therapy intervention is really important, because those people who've got clots in their carotid arteries can have them taken out and within 24 hours. So that's revolutionary. And the fact that we've instituted it, that we've done 32 cases by the middle of January, to me is really important. How did it influence the Health Accord? And again, this is the whole issue about pathways to care. The first way it influenced it is that we needed an integrated air and road ambulance system to work most efficiently to get people to that emergency room. Secondly, when they go through the emergency room, they need to get the CT scanner and their drugs as fast as possible. And that's all about measuring the time it takes for the various components of the pathway to allow those drugs to be given fast. That's a learning, health and social system action, and it very much influenced our recommendation around learning, health and social system. And then the final piece is we needed a way of recording this information digitally so that we could aggregate the information and use it to change practice. And that has very strongly influenced our recommendations around digital health. So let me just, so that's my, so I'm really happy about the information that was presented around stroke care. The second piece is around the cardiac projects that were mentioned, the virtual care, the increased rates because of the new cardiac surgery team, and the Heart Force One. I think that this is very consistent with the recommendations made by the Health Accord. The thought processes were, we have to bring the care to the people where possible. And the two ways to do that, we're already heard. Bring the cardiologists to the patients who do not have cardiologists, travelling clinics. That's happening. The second way is virtual care. And virtual care is we have to buy in. Virtual care in this instance is more efficient, is more beneficial to the patients, and gave them a better outcome, bringing the care to the people. And then the second part of that is, how about making us more efficient and bringing people to the care that you can get in a different arena. Heart Force One is doing that, and it's increasing in the number. But the other part of it is that we're bringing more people to get cardiac surgery that they need than we have previously. So I think that's very consistent with the way that the Health Accord propagated the solutions. And then finally, I'd just like to mention the innovations that's associated with the Cardiovascular and Stroke Institute in a few ways. Number one is that the idea that those three programs would work together is innovative, but it's not surprising that we would do so because the disease process is identical. It's about the blockages to arteries in various parts of the body that affect the heart, affect the brain, or affect your legs. And the piece, I think the really innovative piece that we haven't discussed here is that a primary objective of that institute is to bring into effect, use the professionals delivering care to try and improve the prevention of coronary disease, stroke, and ischemic disease in the legs. And that's going to be a priority for that institute.
Well, thank you, Dr. Parfrey. Certainly open to questions.
Can you talk a little bit about, I know we talked about this earlier, about the new chief that's come, and I guess how important it is that you have a full cardiac team right now?
Sure, yeah, no, it's wonderful. You know, we started off this briefing talking about new physicians and nurses that have joined the province. You know, to really get great people, they have to come and be able to work in a great environment and be part of a team that really, you know, makes them work to the top of their scope of practice. I'm proud to say that because of all the positive things we've talked about here today, because of the agenda of transformation in this province, because of the support of the government and the health authority, you know, we constructed a memorandum of understanding with Ottawa back and forth. It's been a partnership. Our people go there, they come here. And this new surgeon that we hired was a surgeon from the Ottawa Heart Institute. He operated here 5 different weeks as part of that exchange process. He loved it here. Like, who wouldn't love it here? But he also found that he was able to work at the top of his scope of practice, and he wanted to be part of delivering more heart operations in this province and to be able to do heart operations that previously we might have had to send those people out. So Dr. Parfrey talked about bring the physician to the people. I think this is a great example that we captured the imagination of a very talented surgeon and we brought that person to the people, working with our teams to build our program and to be able to offer care that patients should be really proud of if they do need it. Hopefully they don't, but if they do, they're going to be in good hands.
Beth, I just want to add to that as well. You know, the Cardiovascular Stroke Institute, I believe, is part of the reason we were able to attract a world-class surgeon as we did. That institute is going to be one of the best in Canada. Certainly, I believe, the best in Atlantic Canada. And it is that innovation and, that improvement in healthcare that has been able to attract the first assists, the physician, the cardiac surgeons, where we now have the strongest team we've ever had in the province. It's no different when you look at St. Clair's, for example. It's difficult to recruit to St. Clair's because it's an old facility that with outdated equipment and so these decisions are all parts of a puzzle that when you put it together, you start to see a larger picture in how we are improving healthcare. So the fact that we've announced the Cardiovascular Stroke Institute, the fact that that is now in progress has allowed us to attract some of the best cardiac surgeons to that unit, and we have now a full team which will lead to shorter wait times once the institute is built. We've been able to stop the increase in wait time as a result of the additional physicians, but eventually, as a result of this, we will be able to reduce the wait times and start getting ahead of that. And that is significant when you think of our aging demographic, to be able to say that we've stopped adding to the wait time and we are focused on reducing that wait time. It is significant.
Minister, if I might add as well, absolutely agree with everything that's been said about our ability to recruit a world-class surgeon to be our chief here. There's no doubt about it. But the other part that I would add is the day that Premier Fury came down and announced the Cardiovascular and Stroke Institute down at the med school, I was there. There was such an energy in the room that day. People are excited. And we've just come through a particularly hard period, as everyone knows, in healthcare. Folks are tired. And to have something new and innovative and has all the promise to be the best in Atlantic Canada, the best in Canada. We were doing things here that are innovative, haven't done anywhere else in the country. And there's all the rationale in the world, as Dr. Parfrey has just described. People are excited about that, and you need that for recruitment and retention as well. So our teams are energetic. They are really excited to see this step, and we get questions every day of the week. Well, how's the planning going for the Cardiovascular and Stroke Institute? Because people can't wait to see it built.
What's the completion date again?
I don't think we're in a position to have specific dates quite yet. We're in phase 1 right now. Minister, I don't know if you'd want to add to that.
Yeah.
When the new clinical chief
She thinks she's the Minister for Health.
Yeah.
He's looking right at me.
Yeah, so the clinical chief is part of that planning. Certainly Dr. Parfrey is part of the infrastructure planning for that as well. So we are well underway in terms of that. The challenge, Brian, in giving a date is that if we're off by a month or 6 months on that date, you're going to look at me and say, but you're late. So.
It's the same situation with the penitentiary. People just really want a general idea of when.
Yeah, so Dr. Parfrey, in terms of the planning for that facility.
So the infrastructure planning is progressing, but I don't think answering your question is reasonable because it's a cabinet decision. So when the cabinet decide when they're going to start building, they'll tell you.
Can you speak on behalf of the cabinet, Minister?
I think soon we'll be in a position to answer that question.
You mentioned the streamlining the push to the virtual, that virtual will not replace in-care, seeing a doctor. But how tempting is it, though, to put that by the side when you look at geography is the key here? This is the problem we have. The expense and the travel that exacerbates some health conditions in many cases, the stress and financial, and you got to actually travel, sometimes from Goose Bay, which are not long, short flights either. So, and then the opposition yet also is on you for, you can't replace it. So, but and every case is different, every patient is different, but in cases where it just makes so much sense, and it seems like, this is the direction, when you can be proactive, as you said, with some of these conditions. How tempting is it just to put the opposition by the wayside and say, look, we just have to force through?
Well, I think the key is having the right care at the right time by the right provider in the right place. We know, based on what we've done here, we've significantly reduced the timelines. And we've laid that out today as a result of the virtual care that's being provided. That is providing a better quality of life for individuals. And I would say, Cassie or Dr. Connors can probably add to that, but I would say, not only providing a better quality of life, but probably saving lives by reducing that time frame. So we know that virtual is a very solid method of providing care. It doesn't replace in-person care. We also need in-person care, but we need both. We absolutely need both. When you look at the situation in New West Valley, that did save a life. The very thing we're talking about today, and the fact that a virtual physician and the required injection was able to be provided in the time frame that it should be provided, saved that individual's life. So we do need virtual, and especially based on our geography and the disbursement of our population, we need virtual. But virtual doesn't replace in-person care. We need both.
I'd just like to repeat what I said at the last action update. It's here to stay. We've got to buy into it. It fills gaps, and it's good.
Dr. Cassie, could you tell me the current wait list for surgery now?
So our wait list for surgery for cardiac surgery, open heart surgery, is, I would say that it fluctuates daily, but 189, 195 is where our numbers are right now.
And earlier you were told that you're seeing more surgeries being done per week. So how is it that the number seems to be not changing significantly?
So Mark, and you were there, I remember, when we announced the MOU and our partnership with Ottawa. As we emerged from the pandemic and everybody across the country were challenged with wait lists, we thought we were quite innovative at the time, and we partnered with the government and the health authority to be able to arrange with the Ottawa Heart Institute, where we had another conduit where we couldn't operate on all those people emerging from the pandemic in our own ORs, and they helped us, and we sent 50 people there. So now with a full team, and as we build and we support our heart teams here in this province, we've been able to not send those people to Ottawa and maintain our wait lists. They haven't skyrocketed. And of course, as we get, our population's getting older, we're going to have more demand as we go forward. So we've been able to hold the line. Those numbers are not the highest they've been. They're better than what they've been, even though we haven't sent anyone out. So if you just looked at that without understanding those other things, you might think that we're still falling behind. But we have built our teams to handle the demand of the future that we see, and also to be able to manage our current demand. We've upped our number of operations per week by 40%, which just in the last few months. And we see that we're going to continue to up that as the resources allow going forward.
So why stop sending people to Ottawa? Wouldn't that bring that list even further down?
We see that that when we send people away, it's not ideal. Like, if we phone people, and about half the people we contact, they say, I'm happy to have my surgery here, but being sent up there, I don't have many supports. It's a funny, it's an unusual place. It's not I don't have a lot of comfortable environment there. So the reality is, when you go to people, a lot of them don't want to go. And so it's a solution when you have no other solutions. But when building our own teams at home and using the resources it takes to send people away and investing them here at home to grow our program to be self-sufficient is the goal. Now, I'm not saying that if we ever felt that we're in a spot where we had to open up those channels again, there are options to us. We have a partnership. They're wonderful colleagues and friends, and we exchange information all the time. So we have a lever there if we need to. The government has always supported that, but we think we're making progress right here at home.
Mark, I think that if you didn't have people going to Ottawa, the wait list would have gone up. And by now being able to do those people here in St. John's, and the wait list hasn't changed, it demonstrates that we are doing more people. So that 50 people would have been added to the wait list if they hadn't gone to Ottawa.
So in medical terms, would you say the number's stabilized, or you've managed to stabilize patients?
We certainly have, and brought it down by a few. But when you look at capacity and the demand, the number of times each week that we're winning, in which we're doing more people than got referred for heart surgery, we're seeing those weeks now, which we didn't before.
We have time for one more question. I have a question on the Globe and Mail report with travel nursing. Can you give a response to that?
Yep, certainly. So, based on the concerns raised by the Globe and Mail, we've reached out to the health authority. This is a complex issue. I will say that. If you were to go back in time to when the health authorities made the decision to contract the agencies, you would probably undoubtedly have made the same decision. The alternative would have been more procedures cancelled, more services not available, more emergency departments closed. So agency nursing, I've said previously, I'll say again, is a necessary evil. I think every premier in the country, every minister of health across the country, every health authority in the country want to see the reliance on agency nursing go back to pre-pandemic levels. There's a number of reasons why that's happened. I mean, the pandemic, was one of the reasons. The fact that individual nurses, younger nurses especially, have the ability to travel and see different places for short periods of time. They don't get the benefits that they do as a permanent nurse. They don't get the pension. But some people have bought into that. So the concept of agency nursing has grown, and it has become a challenge for health authorities across the country. So we are all trying to deal with that. What I can say is that the Provincial Health Authority, through recruitment, has reduced from its peak. We had about 60 agency nurses in the greater metro region in St. John's. We're now down to less than 20. We have pockets throughout the province where we've seen some reduction in agency nursing. We have pockets throughout the province where we've seen no reduction. But recruitment is what will resolve that. And I outlined earlier today, we're seeing the number of vacancies in permanent positions reduced because of recruitment. But this is it's a significant challenge because there's a global shortage of health professionals, just as there's a global shortage of IT or a global shortage of engineers. I mean, health is not the only area where there's a shortage of health professionals. So competing not only across the country for health professions, but competing globally has added a layer of complexity to this. Because of our demographics, we had more people retiring, for example, from health professions than entering health professions through our own graduates. So that necessitates the need to recruit from outside the province. We've put the most attractive incentives in place across the country. We have put a number of recruitment missions in place. We are starting to see the results of that recruitment. There's a permanent office put in place at the Health Authority, a permanent recruitment office in our department. All of these things are starting to show results. I will celebrate the loudest when we can get back to pre-pandemic levels of agency nursing. I am probably the most fierce advocate of all of my counterparts across the country at our meetings in saying we need to put in place strategies to reduce, but those strategies are recruitment. Obviously, when you have an agency nurse working side by side with a permanent nurse, it creates morale issues. And again, a huge thank you to our permanent nurses who have stayed with us and stayed in the system. But we need to recruit more people, and I've said that from the first week I became Minister of Health. We need to recruit more health professionals to work side by side with those who have carried the weight of having a shortage of health professionals. And we are steadfast and focused, both the department and the health authority, in doing that.
You mentioned incentives there. Have you had a chance or any response from the NL Health Services regarding the incentives? I think you said you were concerned about some of the perks, maybe furniture, all those sorts of things. Have you received any confirmation that that was actually part of it, or that went above and beyond the contract?
So I'd asked my deputy this week to reach out to the health authority to seek clarification on whether or not the letter of these contracts were followed. If the contract was followed by the letter, then the concern is the price of agency nursing. That's known. That's not new news. I've said vocally for months and months that I'm concerned about the cost of agency nursing, not only the dollar figure, but the morale issues and other issues within our health services. So if the letter of these contracts were followed, then the concern is cost, the cost of agency nursing, which is not a new story. If the contracts were not followed and things were done outside the contracts, then there's another concern. But it's premature for me to speak to that until I get confirmation from the health authority as to whether or not cost is the significant factor, or whether furnishings and meals provided were outside of the contractual arrangements.
Do you support the call for the Auditor General to look at this? I know you're saying you want to wait till to see what that happens, but you mentioned it's not news. The news, I think, was the 1 million versus 35 million over a span of time that wasn't even a year. So is that money still being spent, that kind of money?
Well, so the 35 million versus the 1 million is not new news. We've known there's been media reports in this province on the significant cost of agency nursing in the province. And we are working with the health authority to put in place mitigating strategies to get that number down. So, the cost is not new news. The issues raised by the Globe and Mail, the 1.6 million, that may or may not have been outside of the contractual arrangements. That's the new news to me. But the pre-pandemic levels, we've had agency nursing across Canada for decades, primarily used in rural and remote communities, northern communities, areas where it was significantly challenging to fill positions. So because of our aging demographic and because we've had more nurses retire than we had graduates in the province, and having said that, by the way, the vast majority of our graduates from last year's graduating class, we have recruited better than in previous years. We anticipate the same this year. But in addition to those graduates, we need to recruit from outside the province. But there's not a jurisdiction in Canada. One of the things that the Globe and Mail pointed out is we have the most robust, most open ATIP legislation in the country. So I would say if other provinces had the same access to information, they would have the same details out publicly. Agency nursing is not a problem for our provincial health authority. It's a problem for every provincial health authority. It is a problem across Canada. We are all grappling with this issue. And the need for agency nursing is undisputable. Without it, we would have had more closures of emergency departments, more services on diversion. So we absolutely 100% needed agency nursing. The cost is a concern for me. It's a concern for Dave Diamond. It's a concern for the Premier. It's a concern for every Premier in Canada and every minister in Canada. And that is what we're grappling with.
Thanks.
Minister, you started with a statement about the recruitment of nurses, and I'm wondering, do you have time to take a few questions about that?
Yeah, for sure. Go ahead.
How many nurses have been recruited from India?
So we are working with that. In fact, we had a meeting on that just this morning. We had another meeting on the same issue yesterday. The diplomatic challenge between India and Canada has slowed down. We were anticipating significantly more. So we have had over 300, I believe the number is, nurses accept offers to come here. It is now getting through the immigration process. That was slowed down because of the diplomatic challenges. We now have a pathway to start working on that again, and we have started working on it. Without the diplomatic challenge, we were expecting by December 100 nurses, I believe the number was, if memory serves me correctly, by December, and by this time we would have had over 200 nurses. So unfortunately, we don't control the diplomatic relations between Canada and India, but we are dealing with officials in India. We're dealing with the agencies in India. We believe we now have a pathway again, and we are hopeful that we will start to see the flow of nurses from India. We have had some on the ground here, some have arrived, but not nearly the numbers that we had anticipated. Those ones were arranged prior to the diplomatic challenge. Yeah, I believe there are, and I think they were in Central, but they were arranged prior to the diplomatic challenge that had happened. So we started to see some flow, and then it came to a halt. We anticipate seeing that again.
Thank you for being generous with your time. But I have one last question. You mentioned nursing students. I believe at the Center for Nursing Student Studies, the students did a poll among themselves, and of the 103 students, 23 were offered full-time jobs, and that seems contrary to what they had expected. They thought they'd been told that they would all be offered jobs.
So there is a job for every one of them. And let me put it in context by talking about agency nursing. At the peak of agency nursing, we had over 60 in the metro region. We're now down to less than 20 in the metro region. This is an area, most nurses who graduate want to work in the urban areas. Some, thankfully, go to the more rural areas. But the two areas where we are still utilizing agency nursing in the metro region are medicine and surgery. Those are the two most difficult areas to recruit to. So any of those nurses that haven't gotten permanent jobs, who want to replace those 20 agency nurses in St. John's, the health authority will hire them today. So there are jobs available across the province. It is matching people to where the jobs are available and their willingness to go to where they are. Okay, thank you very much.